Good afternoon, all. I want to welcome you to the February 2025 meeting of the Guild of Pediatricians in Private Practice. This is the second presentation for the year. And our presenter today is no other than Dr. Tinuade Ogunlesi, whom we popularly refer to as Kabiesi. Well, I'm sure you will get to know why we call him that as we progress. The moderator for today is Dr. Ireti Fajuri, and I will hand over to her shortly. Also want to let us know that Dr. Mbalaji Lawal, the president and chair of the guild, is unavoidably absent, so he's asked me to send his apologies. I'm sure he probably will join us maybe towards the end of the program. So without much ado, I'll hand over to Dr. Ireti Fajuri, who is our moderator, to introduce the presenter. Dr. Fajuri, over to you.
Good afternoon, everyone.
Good afternoon.
Can I be heard?
Yeah, we can hear you. Good afternoon.
Okay, sir. Good afternoon, dear teachers, seniors, and also colleagues. So this afternoon, we have the privilege of having Kabiesi, as it's fondly called, to talk to us on the topic today. And that topic is shifting the paradigm in the management of neonatal hyperbilirubinemia in resource constrained settings like ours. I'll go on to tell us a bit about our distinguished speaker for today, and that is the person of Professor Tinuade Ogunlesi. He's a professor of pediatrics at the Olabisi Onabanjo University Teaching Hospital in Shagamu, and a consultant in neonatologist at the Olabisi Onabanjo University. Sorry, I got that up. He's a professor of pediatrics at the University of Olabisi Onabanjo University, Shagamu, and a consultant in neonatologist at the Olabisi Onabanjo University Teaching Hospital in Shagamu as well. He is a fellow of the West African College of Physicians, National Postgraduate Medical College of Nigeria, Nigeria Academy of Medicine, and the Royal College of Pediatrics and Child Health. He is the current head of department of pediatrics at the Olabisi Onabanjo University in Shagamu. He's also an external examiner to many medical colleges in Nigeria, and he is the immediate past treasurer of the Faculty of Pediatrics in the West African College of Physicians. He has over 150 scientific publications in the field of pediatrics and neonatology, published in reputable local and international medical journals. He has also authored medical books which were internationally published. He has 3,550 citations on Global Scholar. He was listed among the world's top 2% scientists from Nigeria by the Stanford University for the year 2022. He's currently the editor-in-chief of the Nigerian Journal of Pediatrics, the official publication of the Pediatric Association of Nigeria. He's also the editor-in-chief of the Annals of Health Research, the official publication of the Medical and Dental Consultants Association of Nigeria, OOUTH Shagamu. He is the chairman, Health Research Ethics Committee of the OOUTH. That's just an abridged citation of our speaker today. And I'm sure that we are ready for the excellent dish that he has prepared for us to eat. So I'm going to leave us to savor the dish and enjoy it. Over to you, Dr. Ogunlesi. Thank you. Hello, can you hear me?
Yes, you are audible, Ruthie.
Okay. Dr. Ogunlesi, over to you, sir.
Kabiesi, you need to unmute and speak to us.
Hello, am I audible now?
Oh, yes, we can hear you now.
Okay, thank you. Yes, so I'm grateful for the opportunity to participate in this academic activity, particularly Dr. Eletu, who invited me over. We'll be talking about something we all know about, something we are aware of, and that is neonatal hyperbilirubinemia. Next slide, please. Okay, and the title is as presented by Dr. Fajolu, and this is the outline of the presentation. Next slide. Yeah, so we'll start by reviewing the burden of neonatal hyperbilirubinemia. We all know it's a common morbidity in the newborn period. It's about the commonest reason for the readmission of newborn infants following initial discharge from the nursery. It affects between 60 and 80% of newborn infants. Is that common? A recent large-scale study here in Nigeria put the incidence at 41.9 per 1,000 live births. That study was done across 54 referral level hospitals in Nigeria. Globally, it is responsible for 114,000 deaths among children. And interestingly, between 18 and 20% of it gets complicated and presents with brain damage. Next slide. Next slide, please. Yeah, so the major reason why we talk about neonatal jaundice or neonatal hyperbilirubinemia is because of the risk for brain damage, which we refer to as bilirubin encephalopathy. It is known that total serum bilirubin levels correlate very poorly with encephalopathy risk, especially when there are risk factors for neurotoxicity. And that is why neonatologists tend to consider neonatal hyperbilirubinemia an emergency. Well, it is known that newborns without risk factors for encephalopathy may actually tolerate higher levels of serum bilirubin, unlike where babies have risk factors for encephalopathy. So we have to be mindful of the presence of such risk factors, which we'll talk about later in the course of the presentation. The outcome of bilirubin encephalopathy can be fatal, with mortality rates as high as 36.5%, which has been reported in Nigeria. And survivors can also have various forms of neurodevelopmental deficits. Next slide, please. So the most important complication revolves around free unconjugated fat-soluble fraction of bilirubin, which is lipophilic and so can penetrate cell membranes. So the first step is that it distorts the equilibrium. When there is a distortion of the equilibrium between bilirubin generation and bilirubin clearance. That puts the baby at risk of hyperbilirubinemia. So when you now have a distortion again of circulating bilirubin versus the albumin binding sites, then you have a lot of free bilirubin in circulation, and that is the one that is harmful. So deposition of this free bilirubin in specific parts of the brain, particularly the basal ganglia, is what gives rise to what we call bilirubin-induced encephalopathy. Next slide. So that slide shows the parts of the brain that could be involved in what we are discussing, bilirubin encephalopathy. Those are the various parts of the basal ganglia. But it should be noted that cerebral cortex is usually spared in this disease condition. And that is why it is very rare to have bilirubin encephalopathy with mental retardation. It's because its cortex is usually spared. Next slide. Next slide. Yeah. So there are two types of bilirubin encephalopathy or bilirubin-induced encephalopathy, the acute type and the chronic type. The acute type is transient, reversible, and usually manifests in the first 2 weeks of life. Whereas the chronic type, which is permanent and lifelong, which is also known as connecteros, tends to persist for life. Interestingly, other parts of the body can also be stained by bilirubin, not just the brain. The intestinal mucosa, the renal tubular cells, the pancreatic islet cells, they can also be stained. But the clinical relevance of such staining remains unknown as at now. Next slide, please. So how does it occur? You have, following the staining, there is some coupling of oxidation processes in the mitochondrial apparatus, and then that leads to a cascade of events, which eventually leads to neuronal death, and then you have a condition that we call chronic bilirubin encephalopathy, which is irreversible. Next slide. So the risk for bilirubin-induced encephalopathy goes thus. When there's a delay in diagnosis and there's delay in effective treatment of unconjugated hyperbilirubinemia, that leads to prolonged exposure of the infant to high level of free bilirubin. And that is the one that is neurotoxic. Next slide. So what are the risk factors? Hemolytic conditions, hemolytic disease of the newborn, sepsis, GC3 deficiency. All this will generate bilirubin load. Then when you now have conditions like hypothermia, hypoglycemia, metabolic acidosis, hypoalbuminemia, elevated free fatty acids, and then immaturity of the blood-brain barrier, as well as sepsis with or without meningitis. These are risk factors for bilirubin-induced encephalopathy. People are now talking about possible genetic predisposition, but this is yet to be brought into clinical relevance. Next slide, please. So there's something we call low bilirubin connecteros. I'm sure we must have encountered this somewhere in our practices. You have occurrence of bilirubin encephalopathy at serum bilirubin levels far lower than the expected for encephalopathy. Literature has taken note of possible developmental variability and the permeability of the nervous system to bilirubin. And that may explain why some babies will develop connecteros at a particular level and another baby will not develop connecteros at that same level. However, in the presence of high serum bilirubin level with risk factors, then low bilirubin kinetics readily occurs. Such factors include, as mentioned earlier, prematurity, hyperbilirubinemia, sepsis with or without meningitis, intraventricular hemorrhage, periventricular leukomalacia, and use of drugs which compete with albumin which compete with bilirubin for albumin binding sites. Next slide. Okay. So we are familiar with the manifestations. The early phase characterized by lethargy, post-shock, hypotonia. Intermediate phase characterized by moderate stupor, irritability, fever, hypotonia, opisthotonus, high-pitched cry, and sorry, I'm having some challenges here.
Wow. We can hear you actually, Dr. Ogunlesi. Hello, Dr. Ogunlesi. Do you want the IT person to control the slides for you?
They should mind themselves very well.
Hello, Dr. Ogunlesi. Can you hear me? Yes. Go ahead.
okay. I apologize for all these interruptions due to network issues. So I was describing the manifestations of acute bilirubin encephalopathy as something we all know about.
In progress.
The early phase, the intermediate phase. Next slide, please. So the advanced phase, that's where the baby has the deep stupor, high-pitched cry, opisthotonus, and of course, visual and hearing deficits. Seizures may also occur at this stage. Of course, abnormal movements, pedally movement, ROI movement, and mortality tends to occur in as much as 25 to 33%. Next slide. Yes, we should be mindful of this, that it's not just a motor system disease. Bilirubin encephalopathy also destroys the auditory apparatus. So hearing tests to be carried out for newborns who receive care for hyperbilirubinemia, because the auditory brain stem center is primarily affected. Next slide. So this is a typical connectorous facet You can see the scared appearance of the baby. Baby looks scared. That's a blank stare from facial dystonia and then paralysis of upward gaze. There may also be certain some appearance of the eyes as well as eyelid retraction. Wandering or disconjugate eyes may occur in both directions, vertical and horizontal. Next slide. Well, making the diagnosis tends to be clinical in resource-constrained settings, but of course, the gold standard is to do brain MRI with auditory brainstem response. This combination has been shown to give a positive predictive value of 88.9% and negative predictive value of 98.2%. But for our kind of setting where we don't have such luxury, the bind scoring system based on 3 parameters, mental status, muscle tone, and cry pattern may be used. The eye movement has also been added to the 3, making 4 now. So the total score is 0 to 12. And that is to differentiate bilirubin encephalopathy from other causes or other morbidities which may look like it, things like neonatal tetanus. Okay, so of the we also need to do brainstem auditory response and autoacoustic emission, which is unfortunately less reliable. There's a note of caution here. The bilirubin albumin ratio has not been shown to be superior or better than total serum bilirubin only. So, maybe I shouldn't say we should discard the use of bilirubin albumin ratio, but we should know that it's not better than total serum bilirubin. Next. So the management, I'm sure we're all familiar with this. The goal is to arrest the progression in the early disease.
Hello, Prof. We can't hear you, or is it on my end,
The progression of the condition in the early phase. Because the moment it progresses to either intermediate or advanced stage, there's very little that can be done to save the baby. So, what are the challenges in terms of taking this decision? The first is that there is no known definite relationship between the duration of extreme hyperbilirubinemia and the development of bilirubin encephalopathy. So it's difficult to say because this baby has been jaundiced for 3 days, the baby may have encephalopathy, or this one that has just been jaundiced or that has just been noticed to be jaundiced for 12 hours cannot have encephalopathy. There's no such known relationship. The second unknown one is the definite cutoff serum bilirubin level for the development of bilirubin encephalopathy. You don't know at which level of bilirubin it may occur. You don't know for how long the baby should have had that level of bilirubin before the baby can get stained. So there's a need to be aggressive when the baby presents with severe hyperbilirubinemia, particularly if the baby is sick, if the baby is preterm, and if there are indications of hemolytic process going on. Next slide. So these are some of the novel treatment options. They are still at the experimental stage, so they are not yet of clinical relevance. The use of minocycline, which is an anti-inflammatory agent, the use of therapeutic hypothermia, like we do in hypoxic ischemic encephalopathy, the use of caffeine, and that's because caffeine is an antioxidant, and bilirubin is known to exert its effect via oxidative processes. Next slide. So we have an elephant in the room. Next slide. And those are the at-risk group of babies in the community who are victims of delay in diagnosis of severe hyperbilirubinemia and delay in the commencement of appropriate efficacious therapies. Next slide. So I've just summarized this local study that was done in Shagamu. Next slide. There's a study of referred babies who presented with jaundice requiring intervention. Just about a third of them, 28.6%, well, roughly a third, had appropriate care-seeking behavior at home, that is before presentation in the facility. And there was a correlation between the use of home remedies and delay in seeking appropriate care, meaning that they kept the baby at home, and so they couldn't seek appropriate care for the baby. In addition, 34.1% delayed care seeking for more than 48 hours. And this particular group presented with very high TSB level. They had a higher EBT rate and a higher bilirubin-induced encephalopathy prevalence. About 2/3 of the mothers actually administered various medications to the babies at home. This include Ampiclox in about 40%, water extract of unripe pawpaw in about 17%, and then glucose drinks in about 11%. Next slide. So that study concluded as follows. Poor recognition of jaundice may no longer be a significant problem in this population. Rather, failure to comply, to promptly seek appropriate health care for jaundice is an issue which deserves stringent attention. Next slide. So the local challenges again, non-identification of at-risk groups. And that's because close to, if not more than half of deliveries take place outside hospitals. So there's, technically speaking, nobody to examine the babies for jaundice or to investigate as due. So there's delayed institution of effective treatment. Almost all infants have been reported, all infants with bilirubin encephalopathy have been reported as referred outborn babies. Only very few were inborn babies. Those inborn babies were actually readmitted. They've been discharged home and they were readmitted on account of hyperbilirubinemia. Of course, no pre-discharge serum bilirubin assay. We'll get to see why that one is important. And then babies are not routinely screened for GCSPD deficiency before discharge from the hospital. So they go home, You don't know who is GC3 deficient or who is not, and then they are exposed to icterogens when they get home. Next slide. Yes, this is another study written by Olusoya and my humble self, talking about reasons why Carnivorous remains an elephant in the room. Next slide. And that paper analyzed the 3 levels or 3 phases of delay. Delay at home in taking a decision, delay after taking decision, delay in seeking appropriate facility for care, and then the 3rd level, after getting to the appropriate place of care, infrastructural problems that may occur and still prevent appropriate treatment. Next slide. So these are the details of the various delays, reasons why people delay at home: cultural, financial, social, tendency to self-medicate with ineffectual home remedies. Next slide. Then this is phase 2 delay, where they have to take a decision where to go. An Egyptian study actually showed that many of them, over 80% of such babies, have encountered health workers after leaving home, and they were wrongly advised. Either they were advised to go and put the baby under neon light, or they were advised to put the baby under sunlight, or advised to give antibiotics, multivitamins, and herbal drinks. Next. Yes, this is about delay within the hospital or facility where there is expertise for the care of such baby. No light in the lab, no blood in the blood bank, phototherapy devices not working well, reasons like that. Next slide. Yes, the role of transcutaneous bilirubin. This is an effective, non-invasive screening tool for neonatal hyperbilirubinemia. There's a strong correlation between transcutaneous and serum bilirubin levels. It is known to be effective in both term and preterm infants. And although there are concerns that transcutaneous bilirubinometer tends to overestimate bilirubin, but it's a reliable index for estimating serum bilirubin levels. Next slide. So what is the role of breastfeeding in all this? Breastfeeding is associated with an increased risk of severe neonatal hyperbilirubinemia in the first few days of life. It is breastfed infants are known to have higher bilirubin levels compared to formula-fed infants for these reasons: poorer fluid intake, less frequent stooling. Of course, the casein content of formula feeds also increase enterohepatic circulation, and so better excretion of bilirubin. Next slide. Phototherapy. We're all familiar with the conventional type. The LED, which is a light-emitting diode device. As for now, that is a standard approach. The goal is to deliver 12 microwatts per centimeter squared per nanometer in conventional phototherapy, or 30 microwatts per centimeter squared per nanometer for intensive phototherapy. The addition of fiber optic devices have been shown to improve the efficiency of treatment. Next slide. Yes. Filtered sunlight phototherapy. This is the use of a canopy of a thin film to filter sunlight rays and remove harmful ultraviolet rays, while delivering only the required blue light wavelengths to the baby. Trials of this were done in Lagos and Ogbomoso, both in southwest Nigeria. Next slide. So in that randomized study, 5 hours exposure per day was delivered to both arms of study, that is conventional phototherapy and then filter sunlight phototherapy. Those who were under the canopy, the mother held them, fed them, cared for them, and there was no interruption of therapy. Both modalities of care have similar efficacies and safety profiles. Next. How about the use of white slings versus white curtains? Randomized controlled trials have shown that the use of white slings and white curtains may improve phototherapy because there is a greater reduction in the level of serum bilirubin, a greater reduction in duration of phototherapy, and of course, a greater reduction in the duration of hospitalization. So the use of white slings and white curtains may actually augment phototherapy. Next slide. The use of aluminum foil reflectors. Studies have also investigated the use of these reflectors and reported that aluminum foil reflectors significantly reduce bilirubin levels and shorten hospital stays compared to standard conventional phototherapy. So we can say that use of aluminum foil reflectors during phototherapy may lower bilirubin level, shorten phototherapy duration, and reduce hospital stay. So further research, however, is needed to establish the effectiveness of this material, these techniques clinically. Next. So what are the actionable steps? What are the things we can do? We should lay emphasis on pre-discharge bilirubin measurement, either using total serum bilirubin or using transcutaneous bilirubin in all infants, irrespective of known risk value. This way, one can predict which baby is at risk of severe hyperbilirubinemia. And such identified babies can be kept longer in the hospital for further evaluation and monitoring. The drawback of this, unfortunately, is that more than 50% of births take place outside hospitals in Nigeria. So such babies may not have the opportunity of benefiting from this method. Next.
Dr. Ogunlesi, we can't hear you.
I don't think that is a problem.
Number one, that I just presented.
Hello, Dr. Ogunlesi, we can't
We
hear
can't
you.
hear you.
All right, so yes, talking about the actionable steps. Okay, I mentioned parent education, which you start during antenatal clinic. universal screening of newborns for hyperbilirubinemia, particularly with emphasis on postnatal examination. This is the earliest method of identifying potentially affected babies. Okay. Then the pre-discharge serum bilirubin measurement should be emphasized. Then home care. Because of our peculiarities in this part of the world, overcrowding and co, baby may have to be discharged earlier than usual. And when this happens, there should be provision for home care. There should be health visitors who will visit the babies at home, assess them, and if they're noticed to have jaundice, then they should be referred for further care. Of course, these strategies may increase healthcare cost. All right, next slide. So, at the antenatal clinic, mothers at risk should be identified. Those with blood group, resource negative, or O group. Blood group incompatibilities. Well, we should involve our colleagues in obstetrics so that they can supervise or encourage the midwives in this sorting, both at the antenatal clinic and the postnatal ward. We should give this condition the same attention we are giving asphyxia. With the national initiative, we should do the same, in my opinion, with neonatal hyperbilirubinemia. Next. Yes, and when babies are noticed in the community to have jaundice, there should be a clearinghouse where they will be taken, and then there will be somebody trained in the examination and then decision taking. We can have sort of what people call yellow house in communities. Once the baby is diagnosed with jaundice, the baby is sent to the yellow house, and then further assessment can take place in the yellow house. Next. So there is a need to have treatment protocols and guidelines which are appropriate for our culture and our level of development. And that's because we need to harmonize treatment practices, we need to remove errors in practice, and we need to optimize care. Information about jaundice can be prepared in form of booklets or pamphlets, which can be given to pregnant women during antenatal clinic visits. This should be written in the various dialects so that the reach will be wider. Okay, next. Next, please. Next. Next slide. Okay. At the general practice and the primary healthcare level, this simple screening tool can be used. And once the answer to any of these questions is yes, that baby should be referred to a higher level of care. Is the baby preterm? Is the baby less than 36 hours? Is the baby older than 14 days? Is jaundice clinically perceptible beyond the chest? Is the baby ill? That is there fever? Is the baby not sucking well? Is the baby not active? And of course, does urine stain the diapers deep yellow? Once the answer to any of this is yes, definitely it means it's a pathological case of jaundice, and so that baby should be referred. Next, please. Next, please. Yes, so this study published by Olusoya, myself, and other workers tried to develop the treatment protocol guideline for parts of the world. Next, please. Next. So we have algorithms that will guide clinical decisions. Next slide. Sorry, I won't be able to go into the details of this algorithm because of pressure of time. Next. Yes, so this is a table that shows actionable levels of serum bilirubin vis-a-vis the age of the baby. Once the serum bilirubin is measured at a particular age, at a particular level, one can decide whether the baby only needs phototherapy or requires exchange blood transfusion. But these guidelines need to be validated in our setting so that we can begin to use it for clinical purposes. Next. Yes, but there's a roaring lion that cannot be totally ignored. We wonder how. And that is the population of mothers who believed strongly in herbal treatment of jaundice. The study we did in Shagamu showed that the use of herbal treatment cut across all levels of education, all socioeconomic strata. So it means it's something that is greatly embedded and needs to be addressed. Next. Yes, we are familiar with the story of Carica papaya. Many mothers will come and tell us they've given pawpaw water. Studies have shown that hyperbilirubinemia in rats that had pretreatment with pawpaw extract significantly reduced, and liver enzymes were also reduced. So it means that somehow water extract of pawpaw, which people use here, perhaps needs to be further researched into so that it can have clinical relevance. Next. Yes, there's also Psychorium intybus, which is found, although of European origin, but it's found everywhere and has in vitro evidence of reducing serum bilirubin. So it needs to be tested for in vivo evidence as well as toxicological screening. So researchers have recommended that these herbal treatments should be considered as complementary to standard treatment modalities. Next. Okay, next. Yeah, that's another plant. That's Fumaria parviflora, which, although has not been shown to reduce serum bilirubin level, but has been shown to improve hepatic conjugation of bilirubin. Next. So in conclusion, severe hyperbilirubinemia currently portends significant risk of avoidable mortality and severe long-term neurodevelopmental sequelae. Lack of poor or timely access to efficacious therapies is the leading reason for the prominence of severe hyperbilirubinemia in our part of the world. Attention must shift from babies seeking care in the hospital after the damage has been done to at-risk babies in the community who must be salvaged. More research is needed on the use of herbs in the management of hyperbilirubinemia. Public and maternal education also needs to be improved. And lastly, the development and active promotion of contextually relevant clinical practice guidelines are urgently required.
Thank you very much, Dr. Ogunlesi, for the lecture. I want to apologize to everyone again for the frequent gaps that we had. I hand over to Dr. Fajulu, who is the moderator. Over to you, Dr. Fajulu.
Thank you very much, Dr. Eletu. And let me once again thank Dr. Ogunlesi for that brilliant presentation in spite of all the issues with the network. And also thank everyone who has stayed with us up until this time. I saw 94 earlier on, and I see that we have increased to 97. We're not reducing. So thank you very much. And the topic for today is definitely a very, very apt topic and very, very topical. We know neonatal jaundice is a major scourge amongst our newborns, and Dr. Ogunlesi has touched on quite a number of things, causes, what mothers do, talked about the genetic influence in the etiology, and also talked about the low bilirubin kinetics. He also looked at the 3 levels of delay, right from the home, making a decision, and also at the hospital, and looked at the elephant in the room. And I thought that was where it was going to end until he brought the lion again. So we have the elephant, we have the lion that we need to look at. And talked about the actionable steps, and he has increased knowledge base and also motivated us even in the area of research. So we look at purple water and we say, oh, is it purple water people are giving at home? We're not seeing the effect of this purple water, but in the rats, it's obviously working in the rats. Why is it working in the rats? It's the etiology of, or the pathophysiology of jaundice in the rats different from what we have in the newborn. Is it a dose-related issue? What about the liver enzymes, even with all these herbs without quantification and all that? And one of the things he said about breastfeeding, touched me, and I'm wondering, I hope we're not sending a wrong signal by saying that breastfeeding increases neonatal jaundice. So those are a few comments that I have noted down, and I didn't hear you talk about Ampiclox drop, which is one of the things that practically all delivery centers send their babies home on Ampiclox, and these mothers are using Ampiclox, assuming that they are treating something. And usually, maybe when the babies now have jaundice, they keep giving the Ampiclox, and they are treating yellow fever until the baby now stops sucking or starts moving abnormally before they present to us. So thank you very much, sir, for this excellent presentation. I'm going to move on to question and answers. So please, if you have any question to ask, please can you signify by raising up your hands while I look at the questions that are already in the chat box. Dr. Tinuade says that a number of centers adapt low-energy LED floodlights for treating hyperbilirubinemia in Nigeria these days, with some good results. These are cheap. What is your take on this, sir? Then Momolara Kehinde, Dr. Kehinde asks, please, what is your opinion on the use of Billy blankets? And I'm looking for any other questions. Okay, Dr. Ezofo says, why can't we as a nation do simple things like examination of the newborn after delivery in the health facility and before discharge, estimate serum bilirubin levels in healthcare facilities as emergencies? Then Dr. Onifade Elizabeth says, in resource-constrained settings like ours, prevention of bilirubin-induced encephalopathy is the name of the game. At-risk babies should be identified before delivery, and prevention will mainly be affected by education in addition to treatment. Who needs education? Everyone, from parents, medical and nursing students, qualified health professionals, to TBAs, and so on. And I really want to agree with what Dr. Nifadi has said there about education. Everyone
But sometimes even our colleagues in the private practice do things that even at the PhD.
Hello, Dr. Fajuru.
Tools for the jobs, Dr.
Okay, can I ask one more? There's a question
Okay, sir.
that talks about you should have shown us pictures of white sling, white cotton, and aluminum foil.
Okay.
So I don't know if at some point we can get those pictures so that we know, we see what they look like. Thank you. Doctor, maybe you should answer those questions first. There are a
No,
few
I
hands
think you should answer these ones first, then we will now ask more questions.
Yeah, there are a few hands up,
and-
like Dr.
Yes,
Ogunlesi.
I've noted that. I've noted that. Dr. Ogunlesi, sir, I've noted you, but I want Dr. Ogunlesi to answer the first set of questions, then you'll be the first to continue when he has done that. Dr. Ogunlesi, over to you, please. Dr. Ogunlesi, over to you, sir. I think he has dropped off again now. Dr. Ogunlesi, is he still on?
No, he has dropped off. But maybe you as the neonatologist can answer the question as a moderator.
Some of them were comments about identifying the at-risk newborn so that intervention can start early in terms of identifying neonatal jaundice. And I stress this to the doctors that work with me that please, if you see any baby with neonatal jaundice, you must counsel this mother up to the point of telling her that whenever she's pregnant, she needs to go to a facility and tell the obstetrician that her last baby had jaundice that needed treatment, either as phototherapy or with exchange blood transfusion. And so that those doctors will look out for jaundice and teach these mothers to look out for jaundice such that when it is jaundice, they come immediately to the hospital. And that if they go to any hospital and they tell them, oh, okay, it's clear by itself, they don't do a blood test or do any test for that child, they can come to us and that we will not turn them away. I once saw a mother, that was her third baby with bilirubin encephalopathy on admission on our ward. The first baby had died from jaundice. Second baby has neurological deficits from bilirubin encephalopathy, and she had a third child with bilirubin encephalopathy. The first one didn't get to hospital. The second one did. So I said the health system has failed that woman, because if she had been adequately counseled, then this third baby probably would have been saved. So education, education, education. I think we cannot run away from that. As per, I think somebody else talked about why can't we do some things at the private, at the health centers, making our health centers well equipped to manage or even identify jaundice. Do a bilirubin check, and you know that, okay, if you see bilirubin greater than this level at this age, then please refer, like Dr. Ogunlesi has shown us in some of his slides. So if simple equipment to measure serum bilirubin are available at the health facilities, then we can immediately refer those people. But if they do not have what to use, then they will just say, okay, and go home, it's nothing much, or go and put under morning sun. And some people will do fluorescent light and all sorts of things, thinking that they are treating. And this issue of ampliclox that I had mentioned earlier. Doctor, I'm trying to look at some blankets. Yes, Billy blankets are useful. They they still have the same mode of action like regular phototherapy. It's just that now you're wrapping a blanket around the baby and covering a larger surface area, unlike when you have the overhead phototherapy that is just focusing on one side. Then you need to keep turning the baby. So it's useful. Somebody talked about the LED floodlights. I don't know about that, and I'm not sure whether they've been tested and proven to be useful in hyperbilirubinemia. But it's an area to study. If some people have reported good results, then you need to do maybe a randomized control trial to see whether this is actually true. And then you can start talking about the use of this LED LED floodlights, low energy LED floodlights. Professor Ogunride, I was hoping that Dr. Ogunlesi will have joined us so that we can hear you, but
Well,
we'll go
the
ahead.
mantle has fallen
Okay.
upon you to answer the questions.
I see that is what is happening, but Dr. Ogunlesi, please try to get him if he can still join us. Dr. Ogunride, sir,
We're doing that.
Yeah, thank you very
over
much,
to
Dr.
you.
Thank you very much, Dr. Julu. It's unfortunate that Dr. Ogunlesi is not around for me to thank him for a very powerful lecture, very powerful delivery. I would love him to hear my suggestion that maybe we should introduce another big animal into the picture, and that's the brown bear. And I think that this brown bear will represent the government. I think the serious government has a very significant role to play in ensuring that the future citizens of this country do not have encephalopathy. I was watching a clip today, and I think I need to ask that question: who owns the neonate? Is it the parents or the government? And from what I was told in that clip, I think the government more or less owns the neonates. In civilized climes, I've read about instances where the government will tell a mother that baby in her womb is their own, and so they will give clear instruction as to what they want done with that pregnancy and what management the child should receive after birth. And I think it's something that we need to look at, because carnitine is a very, very bad thing. It causes a lot of damage to the babies, and it does a lot of damage to the economy of a country, because you have to look after these babies in any case. So I think there's a need for us to start telling government, advocate, and let them get their acts together. Thank you very much. Over and out.
Thank you very much, Dr. Ogunride.
Thank you, sir. Dr. Lukotun, you can ask your question now.
Oh, thank you, ma. It's been attended to. So the question on the LED
Okay.
floodlight. It's
Okay.
been common now in many centers, and but like you said, it's not been validated.
Yeah. So you know that there's a specific wavelength that our phototherapy machines should be at, and also the radiance that should be emitted by these phototherapy machines. So we need to look at what the wavelengths of these lights are, and also look at the radiance that they're emitting. Like Professor Isiaka had said that there's a need for centers to use the radiance meters to measure the radiance to standardize the quality of phototherapy being used. So we need to look at these LED lights, so that we're not just doing things that may put us into trouble later on, and we think that we're treating jaundice in these babies and we're actually causing more damage to these babies. So it's important to look at it and not just say, okay, let's try lights. I know in days past that we used to use fluorescent tubes Then later they say it's blue light. Some people will go and get the blue fluorescent that people use in their bedrooms at night, but it wasn't the right irradiance and the right wavelength to use for this for treatment of jaundice. So it's very important that we get that. Somebody here says that Dr. Akonki says there should be monitoring of serum bilirubin levels at birth, and Dr. Oludare says creating awareness through the media will be a measure in the community. Then Dr. Onifade still goes on to say, neonatologists, please advocate for free healthcare for jaundice babies. Parents cannot afford hospital bills. Okay, ma, we've heard that, but we need the parents to even come to us in good time. On Sunday, I got a call from somebody that works in my hospital saying that, oh, I have a cousin whose baby has jaundice and they've gone to the emergency room and they said there's no space and they were fidgety all over the place. These were a set of twins. One had died because they were at home giving ampiclox and pawpaw water. And by the time they came, the second one was climacteric. Baby was gasping. So before we could even, so we got round around for blood and everything. By the time blood came, baby was already gasping. And this was just barely an hour or so after their arrival. So they came very late, and that is the general picture that we tend to see. There was even a case of a patient we had on the ward. These people had gone to a hospital. Baby was under phototherapy lights. Well, I don't know what type of phototherapy, but the grandmother and the nurse, was the mother telling us that the grandmother and the nurse sneaked in pawpaw water to give a baby on admission in the hospital. So this pawpaw water matter, I think, is something that we really need to look into. First of all, discourage it. And if we're going to research into it to know whether it actually works, like Dr. Ogunlesi had said that it has been proven to reduce jaundice in rats. How fast does it reduce the jaundice is another thing that we need to look at. So if it's reducing the jaundice and adding more to the work of the liver enzymes, then it may be the actions may be contradictory. It's reducing jaundice, is giving the liver more work to do, and the liver cannot cope with contributing bilirubin. So Ogunlesi, I think your hand is still up. I don't know whether it's the same hand or a new one.
Is the old one. There's another question.
It's the old one. Okay. I see, sorry, Dutayo says, please, do we have a standard nomogram for serum bilirubin values at which to start treatment vis-a-vis their postnatal ages in our environment? This is because different centers use different cutoff values. So my answer to that is that there's a Nigerian national guideline for comprehensive new care that has been produced by the federal government of Nigeria. And in that guideline, there is enough information on how to manage jaundice and some other conditions, hyperbilirubinaemia, asphyxia, seizures, sepsis, and all that in the newborn. So the importance of guidelines is that all of us should be doing the same thing. And that guideline is a guide for all of us who look after newborns to be on the same page in terms of what we do for the newborns. So trainings have been ongoing, but we can all avail ourselves with a copy of this comprehensive newborn guideline and utilize it in our various facilities for management of these various conditions in the newborn. Okay. I cannot see, okay, the hand has gone down again. I saw one iPhone hand up, I don't know. If you still have a question to answer. Dr. Onifade has said that we should advocate for free healthcare for jaundice babies. We'll keep on advocating. In fact, we are advocating for free healthcare for all newborns, at least maybe the initial period, so that we can sort them out. I think it's even more important that the lower levels of care have equipment to test for bilirubin, so that they now know which ones to send to tertiary care. So tertiary care is not, secondary and tertiary care are not flooded with babies. Things like jaundice should be able to be looked after even in primary care where you have doctors. At least comprehensive primary care centers should be able to look after babies with jaundice if they have the right equipment. So Tinuade, your hand is up.
Yes, you did say we should avail ourselves of these guidelines. You have to disseminate the guidelines and tell us where to source them from. There are quite a few doctors all over Nigeria. If we don't know where to find these things, we will never be able to all practice in the same way. I know, for instance, here in the UK, I can go on NICE and get a guideline. So if you are online, let us know. Let us know where to find your guidelines so we can use them. Thank you.
Okay, thank you very much. Well, the guidelines have been disseminated at the Neonatal Society meetings, and I know there's a soft copy and we have disseminated this to members online. However, I'm not sure if it's available at the Federal Ministry of Health's site. I will look for the soft copy and share with us as soon as I can get that done.
Thank you.
Thank you. And also I'll also find out if it's on the Federal Ministry of Health. Professor Isiaka is on. I think if she can give information on that, whether it's available on the Ministry of Health sites, I'm not sure. But I definitely will look for the soft copy and share with us. Thank you very much. I think that's okay. Who is that?
Professor Zaka.
Oh, okay. Yeah. Good afternoon.
Good afternoon, everyone. Thank you very much, Dr. Fajolu, and thanks, Dr. Nifade. Sorry, I was running another meeting, but to kindly appreciate Professor Ogunlesi once again for the very brilliant and excellent lecture. The National Guideline for Comprehensive Newborn Care is actually available on the Federal Ministry of Health website, and we've shared it across many platforms. But as you've said, it's a continuous process. It's, we have to keep on moving till everybody gets it. So please, we'll get it across, and we'll also send it to Dr. Iletu to disseminate into the entire groups that attended this meeting and beyond. But it is available on the Federal Ministry of Health websites. And thank you so much, everyone. Thanks. This is really so enriching.
Thank you.
Over. Thanks.
Thank you very much. So that will be done. So, Dr. Iletu, I think my work is done, even though I did more than I was commissioned to do. So I probably will send you a bill for that.
No problem.
Commissioned work. Okay, so once again, I want to thank Dr.
Ogunlesi
Nafseshia for the excellent presentation and all the thought-provoking interventions that he had stimulated us with, and also to thank everyone who has been on. This is truly an international seminar. All our seniors from the abroad, like I jokingly say, have joined us and they have made contributions. And we have all our elders still with us. And I want to say thank you to everyone. Over to you, Dr. Iletu.
Thank you very much, Iriti. Also want to thank everybody who has joined. I want to apologize for the internet challenges that we had from Dr. Ogunlesi's end, not necessarily his fault. We also had the same problem of getting this meeting onto the YouTube channel. So as soon as we got 100 participants, all those who wanted to join thereafter could not log in. So I want to apologize to everybody. This is the first time we're having such issues. Going forward, I think we'll do a lot better than we've done today. But my special thanks must go to Dr. Ogunlesi. Despite all the hiccups and challenges, he was able to deliver his lecture, even though he couldn't get back online to attend the questions. Well, thank you, Dr. Fajulu, for standing in. As a matter of fact, if you realize when we're choosing the moderator, each time we're choosing a moderator, we always choose a moderator who is also versed in the field of the lecture. So if there are challenges like this, they'll quickly step in and sort them out. For those whom we couldn't answer their questions or who raised up their hands and were not recognized, we apologize. Going forward, this won't happen again. And on behalf of the president of the guild, Dr. Mobolaji Lawal, I want to say a big thank you to everyone. This recording will be shared in the next 24 hours or even earlier than that. Once we get the clean copy of it, we'll share it. And I assure you that once I get a copy of the guideline that was discussed, I will also share that to all the various groups that are requested and all the groups that are related to the guild. So thank you very much. We hope to see you again on the 4th Thursday of March 2025, where I can assure you we have an interesting lecture and also with some international perspective to it. Thank you very much and have a wonderful evening. God bless you. Bye-bye.